heart is responsible for cardiac contraction and the ejection of blood, which is the muscle part. Myocardium. Endo is the inner, epi is the outer, and peri is the sac around the heart. So, which following regarding the right side is correct. It is a much lower pressure than the left side. It only has to pump to the lungs. The left side has to pump it all the way to the body. So the left side is a high pressure. Stimulation of the parasympathetic nervous system, which would be the vagus nerve. If I stimulate the vagus nerve, what am I doing? Slowing the heart down. I'm stepping on the brakes. So it doesn't totally block the AV node, doesn't do anything to epi or norepi. You don't get a big P wave, but you get a slowing down of the SA node and a slowing down of AV conduction. It slows everything down, putting the brakes on. Common complaint, fatigue. Yeah, diarrhea is not a heart attack complaint, is it? A cough, headache, probably not cardiac. Which is the following clinical findings for left side heart failure? So if the left side's not pumping good, where does blood back up?
Lungs.
What do we hear? Crackles. If we have edema in the body, or JDE, that is right side heart failure. And yes, Regalip has to do more cardiomegaly.
I wish I got those questions.
S1 heart sound, the love of Love Dove. The S1, the first sound we are hearing, is the closing of the mitral and tricuspid valves. Because this is the heart squeezing, so it's closing those valves and opening the semilunar, aortic and pulmonary semilunar valves. Those valves close because it prevents blood from going backwards. That lub sound is those valves closing. Dub is going to be
The other ones.
the semilunar valves closing. The thousands of fibrils at the, distributed throughout the inner surfaces of the ventricles at the end of the cardiac conduction system are the Purkinje fibers.
Not that one, right?
It's literally what I was looking
They only have 3 bundle branches, you have thousands. During refractory means what? Resetting, recharging. Okay. During the refractory period, the heart is in a state of partial repolarization. Maybe could be in a state of depolarization too. Okay. Partially charged but cannot contract. Absolute refractory? Yes, but it doesn't say that. It just says refractory. Depleted of energy and needs to recharge, that is depolarized. Right? Depolarized or in the process of repolarizing. That's the refractory period. Now, again, if it said absolute, this would be a correct answer, but it doesn't say absolute.
I got that one. I went with the first answer.
In most patients, the SA node gets blood from the
Yeah, right corner.
right coronary artery. Where's my SA node? Up in here somewhere. Here's my my primary coronary arteries, the right one and the left one. Which one goes to the SA node? The right one. If the heart's secondary pacemaker becomes ischemic and fails, so the primary already failed because now the secondary is failing, what's left? SA failed, AV failed, we're left with ventricles, so the rate is we're less than 40, usually 20 to 40, could even be slower. What does the P wave represent?
Depolarization.
It starts with an SA discharge, but it represents all of the atria depolarizing. Okay. The PR interval is the delay at the AV node. Brief pause between the P and the QRS is the delay at the AV node. PR interval.
Dr. Morehouse?
Sir.
Back to the SA node question about where it gets its blood from. In your PowerPoint, it also states in some people it gets it from the
Yes.
left circumflex artery.
Yes.
So if the left circumflex artery is an answer,
Most patients, right there in the question,
right?
most patients, it's 68 or 71%, forget, the AV is the other one. It's either 68 or 71% get it from the right. Where was I? Which represents ventricular depolarization, QRS. P wave was atrial depolarization, QRS is ventricular depolarization. PR should be 0.12 to 0.20. The ST segment should be at the level of the isoelectric line, not up or down. When doing CPR on cardiac arrest, it's important to remember full chest recoil. Limit interruptions for 10 seconds, not 20. Proper compression to ventilation ratio for 2 rescuers is 30 to 2. I'm assuming, I hate to assume, but I'm assuming this person's been doing it a long time because that was the rules like a long time ago. Advanced airways in place, you should ventilate at a rate of 10 breaths a minute. Or 1 breath every 5 to 6 seconds. I'll rescore. These 10 people are getting an extra point.
Thank you.
There you go.
It would make my life a little easier if you're willing to tell me who you are of those 10 people. Bianca.
I didn't really let my hands up.
Jason. Robbie.
I didn't read the question. Like, I just didn't read the question.
I'm like, all right, good to go. Bam.
Why'd you do this one on too?
No, I the ones that I did.
Cool.
I didn't read it.
It's gonna be really bad if 9 people raise their hand. You'll make it long.
I thought you were gonna
Or
get 11.
11.
Yeah, that's all.
I have a question going back to number 5, because I was stuck I'm sorry, I had to find it before I raised my hand. I was stuck between these two. I got it right, but, so, in the book, it says, on page 1168, when S1, 2, and 3 sequence is heard in adults, it is called a gallop rhythm because it sounds like a horse galloping. It's heard in early ventricular, diastole. The sound is caused by vibration of the ventricle walls during rapid ventricular filling and is often associated with heart failure. Is that just specified to any type of heart failure?
Correct. Doesn't mean it's left.
Okay, I was just making sure.
No, that's fine. Oh, where were we?
At 19.
Okay, 19. Dosing regimen for epi is in cardiac arrest, 1 milligram, 1 to 10,000 every 5 minutes. All right, which drug do we give for refractory PFib? Of the choices here, amiodarone. What else could we give? Or, right, so, which of the following pulseless rhythms is shockable?
BTAC.
There's only 2 shockable rhythms with no pulse. One's VFib, the other is VTAC. Regardless of the presenting cardiac arrest rhythm, so they are in cardiac arrest. Doesn't matter what it is, PEA, systole, VFib, pulseless VTAC. The first drug, IV drug, not oxygen, first IV drug we should give is
Happy.
epi, which is a vasopressor.
Would you consider also, I don't remember, I went back and forth on this a couple
We're
times.
giving it not to speed up the heart, to constrict the vessels to prime the blood. It's a vasopressor. There are other options. The other drug is actually called vasopressin,
I'm just done. I don't.
but the success rate with vasopressin is minuscule compared to that one. Plus vasopressin is expensive, so nobody, It's like, if 100 million people went to cardiac arrest, they'll try vasopressin on one. Everything is that.
Okay.
You can briefly interrupt CPR to check the rhythm. Right? Common cause of cardiac arrest. I'm hoping somebody misread that. Hypervolemia is not a cause of cardiac. Hypovolemia is. Having too much fluid doesn't cause you to cripple. Treatment for bradycardia with compromised cardiac output. Pacing. If this said 1 milligram, yes, but this is the wrong dose of that.
I'm here.
Is that your mom? No, girlfriend? Serious. My wife. I get it. Yes, sir.
Bump heads.
Why would it be B if that was one?
I would accept that also.
Oh, okay.
I would accept it.
Alright.
The best would be pacing.
Okay.
They're crashing. But you could do one, it's just the wrong dose. That's why I won't accept it here. Electrical capture during pacing is characterized by a pacer spike with a wide QRS. Not a narrow QRS. So it's going to be wide with a pacer spike. And it doesn't change the height of the QRS. There's no low amplitude to it, right? It's just a pacer spike with a wide QRS. So, your question?
So I don't think that you're gonna go
I'm here.
back on, but, so, before I present my argument, does the pacing create the wide QRS?
Yes.
I guess I misunderstood the question because it said electric capture during.
Pacer spike with a wide QRS.
Yeah, so I guess I was thinking like, what you could pace. Because of the way that they're, like, why would you pace?
Okay.
You know what I mean?
And I understand that, but that's not the question. The question is saying capture during pacing. So we're pacing, doesn't matter why. What do we see? What are the characteristics?
Lost that one.
Necessary to evaluate cardiac dysrhythmia in the context of
Overall.
the
kind of-
patient.
Yeah.
Remember, treat our patients, not the machines. Decreased cardiac output secondary to heart rates greater than 150. Wow, worksheet question. Right? Is because poor cardiac output. So decreases in stroke volume and ventricular filling. Bombardment of the AV node by more than one impulse, potentially blocking the pathway for one impulse, allowing the other one to stimulate cells that have already depolarized. So it's getting caught in that loop. It's bombarding it over and over and over again. It is re-entering the electrical conduction pathway. Re-entry. Ectopy means what? That's just a weird pacemaker site. PAC, PJC, PDC. What is excitability? That's every cell. Can be stimulated. Be excited. ECG shows artifact. You should
Sure, yeah.
tell them to stop moving, stop the truck, make sure the electrodes are stuck real good, maybe shave the patient under the electrode, not here. Spies like us reference for those who know obscure 80s movies. Electrical wave moving in the direction of the positive electrode goes up on the ECG paper. Always flows from negative to positive. So if it's going towards positive, it goes up. When applying the limb leads, the negative goes on the arm. Amplitude, height on ECG paper is measured in millimeters. Time is measured in
I got that one.
right? 6 seconds is how many big boxes? 30, nobody missed that. Prolonged PR interval is greater than 200. 0.12 to 0.20 is 120 to 200, so it's greater than 200, right? It doesn't mean the AV was bypassed, because if we bypass the AV node pauses it, right? If we bypass that, it's going to get shorter, okay? It indicates there's an abnormal delay, a long delay. QRS should be how many milliseconds or less in a healthy adult? 110, I will take the 120 because that is what I've been telling you, the 3 boxes. So, anybody care to tell me who those two are?
I think I might have been.
Fannin,
I don't
Brandon?
remember.
It officially is 110, but how do you read 2 3/4 boxes? You know, so I get it. A wide QRS
Oh, here we go.
preceded by a normal P wave. So I have a wide QRS, but there's a P wave. What does that mean? It means it started above the ventricles, but there's a problem in ventricular conduction. Right? So it's not that it started in the ventricles, there is a P wave. Right? So there's an abnormality in ventricular conduction.
That one wrong.
But didn't you tell us
Break
that
that down.
if it's a wide QRS, it means the rhythm is ventricular in nature?
I told you when we're doing EKG analysis, first step is look at the QRS. If it's wide, it is ventricular. There is one exception to that, and that's when you see a P wave, which is an abnormality, aberrancy. Right? We're going to talk more about that today with the 12 leads.
But it doesn't mean that it's ventricular in origin?
Not because you have this.
I think that question's worded pretty badly.
Yeah.
Because
I
when
mean,
was reading
10
it,
10
I
to
got it
8,
right,
more
but
people got it
it's
wrong than
preceded
right.
by a few waves, so I'm thinking like it was a few waves after.
Preceded means.
Preceded
before.
means came
Yeah, I
before.
know.
Yeah.
I think,
I'm a little confused.
yeah. I don't know.
What is the end of ventricular depolarization, beginning of repolarization? The J point. Yes, the ST segment is the repolarization time frame, but the J point is the end of ventricular depolarization, beginning of repolarization. Second half of the T wave is the vulnerable period where a strong impulse could depolarize the heart, resulting in a lethal dysrhythmia. That's that R on T. When it lands on that top or back half of the T wave, it causes them to go to VTAC. Sir?
When is the syncing, when on a?
On the QRS. For cardioversion?
Mhm.
Yeah, that's on the QRS. Actually, on the R.
Okay.
Well, Can you go back, sorry? I picked the, I don't remember, I think I picked the refractoriness word really got me, but,
It's in a relative refractory, not an absolute refractory. First half is absolute, second half is relative. In males, the QT interval is considered prolonged if it is 450, right? Actually, anything over 440 is considered long unless they correct it with the machine. So, and 440 is how many boxes, little tiny boxes?
11.
Each box is 40 milliseconds,
11?
So
11
Yeah.
little boxes. 6-second method is counting the QRSs in 6 seconds, multiplying by 10. Analyzing the cardiac rhythm in lead 2, you should routinely evaluate all of the following, or which of the following components. Cardiac rhythm. I don't care what the J point is. There's no questions on T wave width. There's no questions on ST segments. That's all. That's 12 leads. RR interval, which is
Rhythm and rate?
Rhythm.
rate and regularity. You know, what's the distance between the R waves? That's like 300, 150, 100. You know, you can measure that out and determine regularity. Normal sinus has which of the following? Right, QRSs that are up to point, technically to 110, but I'd take 120. 140 is too wide. Right. Consistent PR intervals with upright P waves. This would be down here, makes it what?
Tacky.
Sinus tach, and this here would make it sinus arrhythmia or sinus dysrhythmia when it varies with breathing. In sinus brady, the heart rate has to be less than 60, not 70. Pacemakers, yes, I knew the QRSs are narrow. P waves are not negative, they're always
Positive.
positive. It's silent, so only one there is the pacemakers, yes, I know. Which is likely to cause bradycardia? So last year, almost everybody in the class picked amphetamines. I'm like, really? You're doing meth or speed or something that stimulates your heart, it's going to slow it down? Exercise, does your heart slow down?
No, hopefully not.
Doing speed or cocaine, is that gonna slow it down? No. Hyperthermia, you're running a fever. Your body's metabolic rate goes faster, speeds up. Beta blocker use, what do beta blockers do? Block the beta effect, slows the heart down. I know we haven't got to toxicology, we'll get to that later this semester. What do you think the major sign and symptom of a beta blocker overdose is? Bradycardia. What are we gonna do to treat it?
Give him beta.
Atropine, pace, you know, and in this case, there's a drug that doesn't reverse the beta blocker, but it actually makes the heart beat a little stronger, not faster, and that's glucagon. Which thought regarding sinus Brady is correct. Treatment is always on how well the patient tolerates it. Oh, your sinus Brady at 52. They just don't have a whole lot of energy, blood pressure's great, skin's great, mental status is great. What am I doing?
Monitoring.
Monitoring them. You know, so it's always on how well the patient tolerates it. Regular rhythm, rate is 104. Upright P waves. Normal PR interval, narrow QRS. This is sinus-static. Which of the following differentiates atrial rhythm from a sinus rhythm? Different shaped P waves means it's atrial. Dissociated means the P waves and the QRSs are not connected. That would be some type of a heart block.
Okay. I got that one too.
Early complex, so we know it's a premature something, right? An early beat. Breaks the regularity. Narrow QRS, is it ventricular? Okay. Has an upright P wave that differs in shape and size from the other ones, but it's upright means it is a premature
Atrial.
atrial. If it was junctional, it would be inverted
Inverted
or
or
absent. SVT. Something fast coming from pacemaker site above the ventricles. I'm just not sure which pacemaker site, why? Because it's too fast for me to figure it out. Okay? And it doesn't have to be regular, they usually are, and it can be way faster than 180. Heart rate greater than 150 become unstable because
Reduced filling.
the ventricles don't have a chance to fill up, it compromises cardiac output. Classic sign of a flutter, nobody missed, is the
Sawtooth.
sawtooth flutter waves. I have seen on the national exam, it talks about it as a sawtooth or a picket fence.
Okay.
So just, you know what I mean by the picket fence, you know, all little pointy tops to the fence. Okay. AFib, atrial fibrillation is
Irregularly.
irregular. It is the only one that is irregularly irregular. Major complication from AFib is clots. Right? Which of the following meds would be prescribed for someone in AFib? Right? Digitalis, digoxin, lanoxin, all the same drug. Right? The most commonly prescribed, like 90-something% of the people in AFib get that drug. And Coumadin. What is Coumadin? Why am I giving them a blood thinner? We don't want clots.
So on that one, aspirin would be one, but what about the Lysopro? What- I don't-
Lisinopril?
Yeah.
No, that has nothing to do with
I didn't know what that was. I knew aspirin, so I was like, oh, I'll go this
ACE
one.
inhibitor.
All right.
Junctional escape rhythms or junctional rhythms. Okay? So the P wave is inverted. So it's not peaks. Okay. QRS has to be narrow, right? So not greater than. Did I change the PR interval if there is a P wave? No. But it has a ventricular rate of 40-60. What's the junctional rhythm? Coming from the AV node is
40 to 60.
40-60.
Didn't you tell us before we were going over junctional rhythms that if it's slower than 40 to 60, you
They
can't call
sometimes
it
use-
junctional Brady, they call it
They,
junctional escape?
they do. There's a million people who call things slightly different. but that's the only one that fits the definition. What color is that wall? I'm proving the point. What color is that wall?
But that's a subjective thing. We're talking numbers, which are objective.
How do I find this?
You talk to 25 cardiologists, you'll get 25 different answers.
Right, but I'm not.
It's subjective. No, I get
You are
it.
the one who told
I-
us.
Okay, I get it. There are no peak P waves, or P waves. Peak has nothing to do with it. QRS does not get Y, that has nothing to do with it. PR interval when there's P waves does not change,
This?
right? So that has nothing to do with it, it doesn't get greater, or, you know, or less. But they are a ventricular rate.
But not a 40 to 60.
I'll be happy to pull it up in the book. Show you.
I know, but you told us. that if-
Brandon, I understand that.
Oh.
Absolutely 100% wrong. Absolutely 100% wrong. Absolutely 100% wrong. Yes, it is subjective, and I get what you're saying. There's only one answer. You know, yes, they do frequently use the term escape with junctional rhythms to talk about things that are slower than normal. But some people use it all the time. Right? So yes, it used to be junctional attack, accelerated junctional escape. People sometimes call it junctional escape anything coming from the AD junction. Right? Yes, 10 years ago, that was all 100% absolute carved in stone. And healthcare, medicine does change. You know, so why we do CEUs and everything else. And I completely get it. I get your frustration on that, but there is only one correct answer there. Impulse from the AV node that begins moving up to the atria would show a inverted P wave. Okay. Regular rhythm with inverted P waves means it's junctional. Rate of 70 means it's accelerated junctional, and PR interval is good, narrow QRS. Okay. First degree block, PR interval is long because everything takes too long. Second degree heart block, doesn't say type 1, doesn't say type 2. Okay, so I have to scroll because there's so many. Most second degree are transient and resolve without emergency department help. They don't fix themselves. Okay. Inconsistent PRs with a wide QRS. They don't have wide QRSs, right? That would be third degree. It's not that one. More than half, right, cause hemodynamic compromise and require pacing. No, very few of them require pacing. Some do, but not more than half. Second degree block occurs when the impulse gets to the AV node, occasionally is prevented from proceeding to the ventricles. This could be second degree type 1, where it's predictable every fourth beat or whatever. Could be intermittent, irregular with second degree type 2, but it is still second degree. Sir?
Just a question. I was looking at the second degree block type 2. I know we're not specific, but it says if it's greater than, if the QRS is greater than 110 milliseconds, the block is below the bundle of his.
Which makes it a third degree.
But that was under the explanation of the second.
What page are you on?
Page 1230.
You're under second degree 2?
Yeah, then it says in the box where it says figure 1871, and then it goes to the QR, it's explaining the QRS. 110 or less, and if it's greater than 110, it's a block below the bundle of his.
Yeah, it's a block it's a third degree.
Okay, so.
I don't know why they
didn't want
listed
it
that there.
to
No,
be-
no, I don't know why they listed that there. It's a
Okay.
third degree. Second degree type 1. Going, gone. So it is progressively delayed until one is blocked and then it resets. Key to interpreting a type 2, second degree type 2 heart block is to remember that. Right? Type 2 are irregular, not like type 1. Well, excuse me. Right? They're both irregular. Type 1 is predictable. Type 2 is not. Gets longer, 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 that would be a type 1, not a type 2, right? PR interval, all conducted P waves and their corresponding QRSs are constant. So when I have a P and a QRS, the PR intervals are the same. I just occasionally have a P with no QRS. So when I have both of them, they are the same, yes. And then in most second degree type 2 blocks have more than 2 non-conductive P waves in succession. Yeah, it does happen, but it's not most. Third degree block appears as a slow, wide ventricular rhythm with irregular PR intervals, inconsistent PR intervals.
So,
Yep.
this is the one that we're
Yeah.
talking about? Slow, so it's not, so a third degree is never narrow?
No.
Yeah, okay.
Because the top's doing its thing, the bottom is doing its thing. If the bottom is doing its own thing, those QRSs are wide.
Gotcha.
So the PP intervals are going to be regular for those?
The PR intervals? Oh, the PP intervals? Yes.
So it's just gonna be like the
Just-
pacemaker?
So just using simple numbers. SA node is doing 80. No signal gets through. None. Ventricles are somewhere between 20 and 40, let's call it 30. So the R to R interval, or the P to P interval, P to P would be the SA node, R to R would be the QRSs. They're constant, they're just not synchronized. So does that help?
I think the confusion is because when we see it, like, in the book
The
or
PR
whatever.
intervals
Yeah,
there.
it's like, it says, like, basically, how it's explained is they're not talking to one another, right? Like, they're not communicating. They're
Correct.
You did the same thing, so.
And then-
I'm trying to find
Yeah,
a good
and they
picture.
are, they're like irregular, regular. Yeah, there's no, like, rhyme or reason to them, from our
Yeah.
understanding.
The picture in the book sucks. That's a horrible picture.
So the way, well, I was told to understand it was like the QRSs are regular to themselves,
Correct.
and then the Ps are regular to themselves.
Right, so the
But
So
The
the
book says-
Ps are regular, not irregular, regular. The the Rs are regular, 100% in agreement here. The PR varies.
So, and then I was looking at the book and it said that it's, I didn't pick that answer because it says that there is no PRI.
That's the wrong
There
person.
is no PRI because the atrioventricular rhythms occur in the P. And then if it says on the picture that goes with a third degree heart block, it says QRS may be narrow or wide.
There is a PR interval, it doesn't follow everything's normal and it drops, or a going, gone, or everything is the same size but long. There's no
Over high school.
consistent. It's like, oh, this one's 20, this one's 14, this one's 9, this one's 18, this one's 6, this, it just, they don't line up.
So if there's no PR, it's regular, right, then wouldn't it be regular as well?
Don't make me draw.
No, I,
No, it's fine.
I just want.
Anyways, what does that show me? The regular, that's the SA node firing, right? And for argument's sake, you call that a rate of 80. No signal gets to the bottom, QRS, right? And they're gonna be regular. The P to P is regular. The R to R is regular. But the PR is not and doesn't follow one of those other heart block patterns. I know it says there is none. It's saying there's none because they don't, nothing gets through, but you still see waves. So. Electrical impulse that starts in the ventricles. Wide QRS, rate of 20 to 40, okay? Does it mean there's no pulse? No. Does it change the amplitude, the height? No. Right. Only width. Bizarre looking QRS rate greater than 60. No. If it's started in the ventricles, it is 20 to 40. Idioventricular. right? Most patients are hemodynamically unstable. Yes, it's ventricular rhythm, 20 to 40 or even less. You think they're stable. They're probably alive, they're probably not conscious. Right? So it wouldn't be failure of the SA node, because what would we get? The AV would take over, so we would see not ventricular, but junctional rhythms. Accelerated idioventricular. So it is wide, ventricular, right? It's accelerated, meaning it's faster than normal for the ventricles, which would be faster than
20 to 40.
40. But it's not tachycardia, so it's slower than
100.
100. All right, so it can't be 80 to 120. That's up here is tachycardia. Less than 40, that would be normal, not accelerated. Narrow QRS can't be that. Wide QRS with no P waves. It's the only one that fits. But it would be between 40 and 100 for accelerated. Monomorphic VTAC, they all look the same. Wide QRS, ventricular, right, of a common shape. Monomorphic, the same form. Torsades, also known as polymorphic. It's VTAC, but it has many shapes. This is the getting bigger, getting smaller, they look different. Untreated VTAC becomes VFib. PVCs are ectopic, came from outside the normal pathways. They come from a different pacemaker site. True. Are extrasystolic beats. What's a systolic beat?
Isn't that the opening and closing of the valves? No.
It's not even a thing.
No.
Okay. Are in themselves considered an arrhythmia, but are insignificant. They're not an arrhythmia, they're a condition, right? But they can be significant. Occur later than expected. Well, premature means they occurred earlier than expected. So only one is the ectopic that originates from somewhere different than a pacemaker site. PVCs that come from different sites look different. If they came from the same site, we would call them unifocal. Different sites are multifocal. R on T, when the PVC, right, lands on, the R wave of the PVC lands on the T wave, so the ventricles are not fully repolarized. Okay. You arrive at the scene unresponsive male, pulseless apneic, wife says he collapsed 10 minutes ago. What do? Start CPR. Just because he collapsed 10 minutes ago, does that mean his heart stopped 10 minutes ago? Maybe he braided down. Maybe, we should start CPR. I'm never going to tell you you must or you shouldn't. Okay? 10 minutes. You kind of have that duty. Is that would people expect you to be doing CPR? Right? This is just a guy who collapsed. Right? An hour ago. Probably not. Like that might be why'd you wait an hour? Officer, police officer, you need to talk to them. How to make sure his life insurance was signed. Put the defibrillator pads on a pulseless apneic 60-year-old woman who has a slow, wide QRS. Okay, so it's slow and it's wide, it's ventricular, but she has no pulse. The next thing I should do would be CPR. Even if you're going to defibrillate, which is not an option here. Right? We know he has no pulse. So why am I checking again? If he has no pulse, can he breathe? Do I pace this? He has no pulse. If defibrillation was an option, I could understand that. But even before you defibrillate, what do you need to do? even while it's charging, you're doing CPR. CPR is your option, is your best choice. After 2 minutes of CPR, unresponsive, you assess an unresponsive man's pulse and rhythm. He has no pulse, and the monitor shows VFib. What do we need to do? CPR. We need to defibrillate, so we should do CPR while it is charging. Defibrillation fixes the problem, not the drugs. The defib fixes the problem.
I picked the bottom one. Can you
Okay.
explain why that one's wrong? Even though I'm looking at the algorithm and it
Yep.
does say.
So let's play this out from the beginning. We get there, oh my gosh, no breathing, no pulse. We start CPR. So boom, we're in our 2 minute cycle. What do we do at the end of the 2 minutes? We're going to defibrillate if he's still in VFib. Right? And then we're in our next 2 minute cycle. And assuming the guy stays in VFib, let's just say he stays in VFib. At the end of 2 minutes, we're going to defibrillate. Next 2 minutes, we're going to defibrillate. At the end of the next 2 minutes, we're going to defibrillate. Every 2 minutes, we're going to defibrillate. During the 2 minutes while somebody's pushing on the chest, somebody can work on an airway, somebody can work on an IV
But that's
or
what
an
that
IO.
says. That's what that says. Continue.
Hold on. Somebody could work on the IF. This says following 2 minutes. 2 minutes is ended. What do we need to do? We need to shock him. CPR while the defibrillator is shocking. We're not going, oh, 2 minutes is up. Start CPR and keep working on an IV. We need to shock him.
Okay.
That's why this is wrong. I agree, we are gonna get this in there. That is the priority. He
But
needs
you
to be,
can't shock them with that either, because it's
Sure
still
you can.
charging.
here's my code. This is my imaginary patient, my code, okay? 30, breathe, okay. Last cycle, boom. They're still VFib, what do we need to do?
Shock.
So that's exactly where we are. After 2 minutes, right, he's pulseless and apneic, and we see VFib. That's exactly where we are right now.
But the pads aren't on yet, right?
Maybe not.
Because it says put
Hold
'em
on, let me finish.
Okay, I'm sorry.
Okay? That's exactly where we are. Everybody agrees, that's exactly where the question, where we are.
Preventive
So-
CPR.
Let me finish. Let's do this. Start doing CPR again, innovative. Are we doing that? Maybe, but what does this guy need?
Defib.
He needs defibrillation, whether it's an AED or us with our machine, he needs to be shocked. I don't care if the pads are on or off yet, he needs to be shocked.
Okay.
Okay. That's the priority at this point. Let's start. Okay, let's do CPR, get an IV. Yeah, but what does he need right now at the end of 2 minutes? Needs
Defib.
to be shocked. Okay? Are we gonna do 2 minutes and nothing? No. Are we gonna go back? Okay, 2 minutes, he needs to be shocked. Charge the defibrillator. What does he need?
Defib.
I get, we're gonna get this. I get, we're getting to this. That is my priority. We have to shock him.
I guess I was
That's
just
what
with,
fixes fibrillation.
Yeah.
Defibrillation.
I guess I was just with him. I was thinking if you're already doing it, we gotta wait for it to charge, continue and get the IV while it's charging as well, basically.
Because I'm,
So
Just because
these
that's the
things
order
charge
it is
in
on
10
the.
seconds or less.
All right.
You're telling me you can get an IV, have it flush and good, or intubate in 10 seconds or less?
Me, no, but an experienced person maybe.
No. Even if I gotta go boom, boom, which we put the pads on while somebody's doing compressions, that is my 100% absolutely my priority.
Okay.
so is the bottom answer wrong?
This is the most correct because this
Okay.
is the priority. Even in the algorithm, just coming over to the algorithm, we've done CPR, shock.
Yeah, that's where I get your saying, we're getting ready
And
for the
then,
next shot.
yep,
Yep.
and then, now, there's nothing wrong with while I'm doing my 2 minutes of CPR, you're tubing, you're starting an IV, you're drawing up it, that's great. We're getting a little ahead of the game. We're getting ready, we're being proactive. But
Got to get
2
that shock
minutes,
on.
shock. 2 minutes, shock. That's what has to happen. I'm glad you guys are thinking that. We're not today. Next lab, you're going to start doing megacodes.
Okay.
Yay! Yes. Reevaluate everybody's CPR skills. Unresponsive pulseless apneic patient has VTAC. No pulse, VTAC. Okay? After defibrillating them, we shocked them. What do we do? CPR. Now, in that cycle, I agree, we could be working on an IV, we can be working on an IO, getting a drug on board, but we're not seeing if the rhythm changed, right? We're not checking for a pulse. We already told you he has
No pulse.
no pulse, okay? We don't do more than one shock, we do 8 shocks, and we're back to CPR for 2 more minutes, then we do the next shock. Doing CPR on an 80-year-old, why? In cardiac arrest, it was witnessed, that's why. It's a bad joke, guys. I say that now, when I'm 80, I won't say that. On an 80-year-old who witnessed cardiac arrest by her husband. So he saw her go down, right? Several intubation attempts are unsuccessful, but ventilations with a BVM are producing adequate chest rise. Do I need an intubation? Do I need a king tube, a common tube, an iGel? I'm getting good chest rise. Is my airway okay?
Yes.
Great. IV access has been obtained. Great, got an IV. Didn't even have to go IV. Great. We gave a milligram of epi. Right? Awesome. Cardiac monitor shows a narrow QRS rate of 70. So what rhythm is this? What cardiac arrest rhythm is this? Is it a systole?
No.
Is it VFib?
No.
Is it VTAC?
No.
Then it is
PEA.
PEA. Okay. According to the husband, she had lots of diarrhea.
Hypovolemic shock.
Yeah, she's lost fluids. Okay. For the last 24 hours, has not eaten. So let's see. Are we getting atropine?
No.
No, the rate's above 70. Right? Do we check after every 3 minutes? Every 2 minutes. Are we giving dextrose because we're presuming or assuming low sugar?
No. We have to check.
So let's check a sugar, right? But even if I didn't have a glucometer, it's like, maybe, but is this what's causing the cardiac arrest? It's probably continue this and give fluids because she's had
diarrhea.
Cha.
I just want to point out that P1, I was harping on hypovolemic shock due to diarrhea.
Yes.
And you told me no.
What?
I argued that for like 2 weeks. You told me no. That's why I keep making it a point to say hypovolemic shock with diarrhea.
I would have to go back to the context of the question.
You argued that bleeding was a more common cause.
Oh yeah, bleeding is definitely a more common
But
cause of.
yet, in P2, every single question that has to do with
We are in medical emergencies, not trauma. Most hypovolemia is hemorrhage, without a doubt. But we're in medical, we're not in trauma right now.
Okay.
I got this one right. So just for my own, so if you have hypoglycemia, would you not be doing it because we already discovered that they're possibly in PE.
That is not a recognized H&T, but it is common. It's not considered an H&T.
hypoglycemia.
Correct. It's very common, but it's not an official H&T, according to all the experts. But even with that being said, if you have to pick one, do you think, oh, she hasn't had a big appetite, or she's had a ton of diarrhea? Which one do you really think is causing her to be in cardiac arrest?
The diarrhea.
The fluid problem, not the sugar problem. Middle-aged man in VFib, refractory to several biphasic shocks. Well-coordinated CPR, adequate ventilations, and 2 doses of epi. All right, so what has he not received?
And
An antidysrhythmic. We're still in VFib, so we need something that works on the ventricle drug. So, anything to suggest hypovolemia here? No. Vasopressin, well, that's just like epi. amiodarone, and lidocaine.
No, one or the
Don't
other.
make me pick one. Amiodarone 300. I've seen a almost identical question show up on national exams, but they will have like, amiodarone 150 milligrams over 10 minutes. It's the wrong dose. Lidocaine, 3 milligrams per kilogram.
Wrong
It's the
dose.
wrong dose, so make sure you pick the one with the correct dose. In this case, there was only one, amiodarone. And assaults, trauma, right? Assault. A 20-year-old struck in the chest with a pipe. He is apneic, pulseless, and unresponsive. I know the chances of getting a trauma code back are low, but of my choices here, CPR. Yeah, I definitely want to. Maybe he's got pericardial tamponade, but what does he need?
CPR.
He needs CPR. We got to give him CPR first. And we don't. There's nothing to say it was VFib. It could be asystole, could be PEA. 70-year-old in asystole after 10 minutes CPR. She's been tubed. She got an IV. We've done 3 doses of epi. There are no obvious underlying causes, no obvious H's and T's. At this point, what do?
Transport.
See,
You could do that too, but you can also transport.
Yeah.
Yes, you can. The most appropriate would be consider calling it. If they're not responding, right, after multiple treatments, we need to think about calling it. Especially, I shouldn't say especially. If I made this a 7-year-old,
Transport.
the rule doesn't change. Think about calling it, but the emotional side, nobody's gonna do that. We're gonna transport. Right? But the 7-year-old,
I care about me, Mom.
I do too.
So do I, buddy.
My parents are older than that.
She's going to the hospital.
Yeah. I'm gonna let doctor
Is that
call.
set in
Yeah.
stone? Or is that
It
to
doesn't say
to
call it,
discretion?
it says
Consider.
consider calling it.
Okay, no, I'm just asking, I'm not arguing.
So you
I
would
just,
call
I
medical
truly
patrol?
just don't.
Yeah, you can call medical, you follow your protocol, whatever. Transport it once. And again, there are many, many places, and don't think what we do in Volusia County is a national standard. There are many places, if it's a code, we work it until either 1, we're done, they're dead, or 2, we get ROSC. If we get ROSC,
Then you transport.
we transport. They don't transport and do CPR in the majority of the country.
Okay.
Florida, we do CPR in the moving truck all the time. Most places, don't happen. It's working, either we get them back or we didn't. We get them back, we transport. If we didn't, we didn't. So I get, especially locally here, they work just about everything. So, but yeah, if they're not responding, especially when they're in a system, we don't work. Somebody else had a question? I'm sorry.
Yeah, I guess the one thing that made me choose transport is 10 minutes just seems like a
Short time frame.
Right.
Volusia County's protocol is 20, just so
Okay,
you know.
Okay.
But we're working a code. 10 minutes is a long time. I started, 2 minutes later, she's doing it, 2 minutes later, I'm doing it, 2 minutes later, she's doing it, 2 minutes later, I'm doing it. We've been working at this for a while. They're tubed, we got a line, we've done epi 3 times in the 10 minutes. So every other cycle, we gave epi, 2 cycles later, we gave epi, 2 cycles later, we gave epi, we're at that 10-minute mark. Absolutely nothing has changed.
Right. Okay.
Probably gonna be bad. It doesn't say don't continue, it just is seriously consider stopping. Volusia County, your medical director here, and I believe Dr. McCabe also is 20 minutes.
well, we worked on last night, we did 2 rounds of asystole and called it. 'Cause there was
By
no-
protocol, or do you have to call a doctor?
No protocol.
By protocol.
2 rounds of pharmacological intervention, if there is no change, confirm in 2 weeks, we're done. Call it off.
Asystole is really not a sign of life. It is truly a sign of death. The exception, because there's always exceptions to everything, the exception to that is when it is the electrocution, lightning strike type thing, because you have a real good chance. And every electrocution, whether it was electricity or a lightning strike that I have worked, that I have gotten ROSC on, we have gotten ROSC within 3 or 4 minutes. Like, you get them very quickly,
Okay.
or you don't get them. You know, but that's the one that have a chance. The other ones, they don't have a chance. Right. Means electrically, the heart's still doing something, so. Yeah, I'm sorry, anybody else have a question? No, okay. VFib occurs when? All of the many cells in the heart depolarize independently rather than in a response from an impulse. So they're all doing their own thing, the heart's just kind of quivering. Which of the following regarding asystole is correct? Prolonged myocardial hypoxia. The heart is dead. Right? If I disconnected the leads, what do I see? A dashed line, not a solid line.
Okay.
This is monotone.
Yep. Okay.
So, when you're in a systole, those cells, are they dead or?
Dead. There is nothing happening.
So then what's the point of doing CPR?
On those,
Because the cells are dead, there's not, I mean, it's dead.
correct. There are places where my friend Jacqueline works up in Montana. They're in a systole, we're done. They don't work them. Right? If you find them in that, a lot of places are cool with you not working it. If you are in, now imagine they're in VFib, and I shocked them and they went to a systole, that's a little different. We still have electricity, right? But when I find them in VFib, or excuse me, when I find them in a systole, the chance is pretty much zero unless it's the electrically induced. So yeah, it's because these cells have died. I'm not a big fan of working in the system, the show code. But
You can't bring those cells, like, so if you shock them from VFib, they're probably gonna go into that anyway. That's the natural.
but I'm gonna work it a little bit because in the next 2 or 4 minutes, I probably can get them out of a system.
Yeah, there's a chance.
But if not,
Go into the other,
right,
I mean, to me, is,
yeah. No, a systole is more of a confirmation of death.
I'm not saying I'm not gonna work, I'm just
No,
saying,
of course
it's
not.
like, the cells are dead, what are we
Right.
doing?
And that's where a lot of places, if you find them in a systole, you don't even have to work them. I always challenge that one and say like, I really don't need a monitor to tell me if they're dead. But some medical directors want that. So it's frustrating when you put them on the monitor, because that's what the medical director wants, because this guy's clearly dead, and you've got this. You're like, oh, they got the one complex of it, and you can't go, just take this little part and take a picture of that. And put that. No, because all of that electronically is imported into the report. It's there. Because then when you don't do it, and they go, oh, you violated protocol, and not your medical director, the family's lawyers. They get that stuff too.
I was just looking at ours, and it says after 2 rounds of epi. So where would that put us as a time frame?
Probably about 6 minutes.
Okay, so,
Meaning, I got there, I started, somebody had to get an IVIO, we're in about 2 minutes, we give epi, about 2 minutes later, we give epi. You know, you're in the 4 to 6 minute range.
so as long as you have a confirmed airway.
That's the new release kind of one.
And you just need medical.
Wow, awesome. Looks like they talked to Dr. McCabe. So they want to confirm the airway here, a lot of places like,
And that
I gotta make
is
sure air's
either
going in and out.
Intubation or King tube.
Yeah. Or innovation or any superglide. I don't like the fact that they wrote King tube, because what if they switch and use an iGel, or, have to rewrite the whole protocol.
I think that's the only one approved in Volusia County right now.
My point is, if they approve
But
something
they
else, they
still
have to
have to change
rewrite
it.
the whole protocol.
Yeah.
Just say like,
Mhm.
any superglottic or innovation.
Advanced.
Firing of an artificial ventricular pacemaker. Pacer spike and a wide QRS, because it's pacing the ventricles.
I have a question.
Yeah,
Okay.
I kinda answered it, but when you're pacing, so no matter what, when you're pacing, it's gonna hit a wide QRS, no? So it's not gonna pace your spike.
When it captures, yes.
So no matter what, even if that says ventricular and the other one didn't say.
No, because there are atrial pacemakers that can create a P wave,
That's what I was
because it's only
wondering.
up in the atrial tissue.
So it's not always gonna be
our machines are always like, probably 85–87% of all pacemakers are going to be ventricular.
Okay, but there is a possibility that.
Yes,
So,
even in your
Nero?
book.
Where they look
I would have paid, but that's here.
I'm not doing that anymore.
1, 2, 3, 1.
The accent.
131. Spike QRS, spike QRS, spike QRS. This is ventricular. This one here, they call it AV sequential. We're doing
Yours
change
is
one.
really good.
Spike P, spike QRS, spike P, spike QRS. Yeah, there's a spike QRS is
But the QRS will always be wide.
there. Always, every time we do that.
That's what I was wondering, because even if it's atrial, like, it should be narrow, but every time you.
No, so you're not just pacing the atrium, you're passing the pacemaker.
You don't have to, it doesn't have to be, it could be like sinus brady where it's not wide.
But when I start pacing it, I'm gonna have a pacer spike and wide.
But yeah, my question is, because any slow
I
rhythm.
don't mind it. I
Yes.
like listening.
You pace any slow rhythm.
I think that's what messed me up on those questions, because I was like,
No, I get you.
Yeah, I was wondering.
70–80% of ventricular filling occurs during,
gravity.
by gravity, during diastole, so it is passive. It just, gravity fills, right, very passive. The AV junction, okay, is the AV node and the surrounding tissue, which is the bundle of heads, okay? It's both of these, so it can't exclude that. It's not the fastest pacemaker, right? And it doesn't get blood from the circumflex artery. So where's my AV junction? Kind of right here. Here's my circumflex artery. Way over here. Here's my left anterior descending. It's not the circumflex. Repolarization begins when? Sodium and calcium channels close and everything starts to get pumped back and reset.
Bless you.
Who is it?
Is your girlfriend, Kenny?
Dave's not here.
I wish. I said I wish.
All right, after delivering a shock to a patient in pulseless VTAC. CPR. Immediately we start CPR. Right? According to Langton's triangle, lead 2 is assessed by placing the negative on the right, positive on the left leg, negative to positive. 39-year-old in a systole unresponsive to CPR cheetosis of epi. They have an IO. You should focus on calling it's not an option, but making sure I've ruled out reversible causes. Recommended treatment for 3rd-degree heart block associated with bradycardia is pacing. I'm hoping somebody was thinking.
It doesn't even go
apathy.
past the AV node. It doesn't even, it's, oh.
Right.
Oh
So-
my gosh.
So the best option is pacing for 3rd degree. These are not as good of a choice. But adenosine is definitely no. Adenosine is fast.
I know, I was me too. Why would I say that if it wasn't me? No, it was me. I didn't read it. Turn it off and move